Welcome, welcome, welcome. Summer edition. We've both been in Hot Topics and Pediatrics at Disney World. I love the Pandora ride, and Matt does not do any rides. But as promised, the podcast pediatrician conclusion of Strep. But first, a little popular culture. Okay, quickie, we're going to talk about our favorite TV shows and podcasts. I'll start, Matt, because you don't watch TV. So I'm going to say that there is a show this year called This Is Us, and I started watching. It's a tearjerker. If you don't cry, then you've got a problem. Mm-hmm. But I think it's going to be one of those all-time shows. We talk about our favorite, Mary Tyler Moore. This Is Us is an all-time series, and it's a network series. It's got Mandy Moore. It's got Peter from Heroes, Ron Cephas-Jones, which is Peggy Schuler's dad, and it is a fabulous series in all ways. You got to watch it, man.
I've watched a few episodes with my family. Oh, I agree with you. It's really a fantastic show. And head and shoulders above most stuff.
And you know what's coming soon in a few weeks? Daenerys. Game of Thrones.
Yeah, I keep meaning to maybe start watching that. But.
It's so good. I know they got the nudity part because it's HBO, but it's so good. And Walking Dead will be coming back at some point, which I know you don't like at all.
No.
But I say it's not a zombie series. It's a good series. It just happens to have some
bunch of zombies.
And just throwing out a few other things. Catastrophe just throughout its third season, only 6 episodes a season. It's for adults. The 2 writers are the 2 stars, and the chemistry and the writing is great. Master of None, Aziz Ansari.
I've heard that's good.
It is really good. Mm-hmm. He did an episode last year. It was about his parents. This year, the episode on religion. Mm-hmm. And most shows don't want to touch religion, and it's really good. And Broad City comes back, and Billy Eichner. You love Billy on the Street?
Billy on the Street?
Exactly.
How did I know that?
How did you know that?
Because my son and my daughter will every once in a while say, Billy on the Street, for no obvious reason.
Well,
I still don't know anything about it.
It's great. Also, he does Difficult People. For you Seinfeld fans, there's an online with Jason Alexander from Seinfeld, George Costanza, and his son Gabe, and it's called Dinner with Dad. It's just a quickie. I think it's on Hulu. It's very funny. All right. Anything to add for TV shows? Nothing.
I got nothing.
Okay. How about podcasts? So Modern Love, the podcast. Still love it. Science Versus is coming back with new episodes with that host Wendy Zuckerman. Radiolab, which is great science. And the CRISPR I mentioned before, it's great. There's something called Remarkable Lives, Tragic Deaths, which is really cheesy. Huh. But it is a 20-minute, 23-minute, a famous person who had a great life and a remarkable death. Like anything from John Lennon to...
Don't know that one.
Rasputin and such, and they act out parts. That's the part that's kind of cheesy. And of course, This American Life and Matt.
And of course, there are those podcast pediatrician guys.
Yeah. Yes. So listen, download, give us your comments, especially if you have comments and ideas for next season.
Yep, happy to take them. And we certainly, our palette is broad here. We have no problems at all with touching on whatever topics that people want to hear about. And we'll do the research. You do the listening.
Say goodnight, Matt.
Good night, Matt.
Oh, shut up. Next.
Billy on the street. Billy on the street. He's making dreams come true. Billy on the street.
We are sharing our own personal opinions on pediatric care. Always talk to your own pediatric caregiver about your child. Pediatric caregivers should always consult expert guidelines and consider their own community's standards of care.
Okay, Matt, I know we're mostly doing strep throat, but I got to mention strep ani.
Is that what you
around
call
the
it?
anus. I call it strep ani. What do you call it?
I call it peri-anal strep.
Okay, well, again, potato. But it's, a kid who comes in and maybe they're talking has vaginitis with a girl, and it just has this very characteristic bright red ring around the anus, and it's tender.
Yeah, it's like fire engine red.
Right.
Yeah, it's really disturbingly red. And how do you go about diagnosing that?
I will usually use rapid strep.
Yeah.
And we'll talk about rapid strep in a second, but and roll it around there and see if it's positive. And it usually is. Now, hasn't happened, but if I was sure it was strep ani and the strep was negative, I would still consider treating it.
Yeah. It's funny. There was an article, I think it was back just after we finished our training. And I remember the article because it was called, Are We Sitting on Too Much Strep? and just pointing out that this is a real and true entity.
You know, it's all about the title. Like when I do conferences and people put out boring titles. I mean, you gotta have a
sexy it up a little bit.
Grabbing title. That's a good title.
Yep.
All right, Matty Ice. Peri-tonsillar abscesses.
Peri-tonsillar abscesses. These are nasty things. So a local complication of strep can be peri-tonsillar abscess or a retropharyngeal abscess, and these should be considered in a patient with unusually severe or prolonged symptoms or localized pain associated with a high fever and a toxic appearance. And this is yet another reason for us to stay away from encouraging people to use telehealth options, particularly outside the medical home. And this is unless the telehealth practitioner is particularly astute, because this is a potential disaster brewing.
Teenagers, I see a lot of college kids, and their throat's killing them. You look in there, and you see the classic mass effect. One side is just pushing the uvula over to the other side. And I have noticed over the years that it seemed like these used to get drained automatically.
Right.
I remember in residency with an ENT doc who basically had a duck because sometimes the pus shoots out.
Oh, it does
and they
shoot
do it,
out.
and they even do it in their office.
Right.
But I see more and more that they were going to conservative treatment, that they just put them on antibiotics, often Clinda, and they don't actually need to get drained. It is something that if you have a severe one, or certainly a second one, you should yank those tonsils out.
Yeah, for sure.
No question.
No, one of my a good friend of mine's wife had one of these a few years ago, and had it lanced right there in the ENT's office,
Right.
which seemed, well, I guess you need to be an ENT for that, because there's all kinds of dicey structures back there. You know, like I don't know, carotid arteries and whatnot. So
Brain's not too far
That's
back.
right, brain's not too far away. So I'm glad the ENTs do that. So moving on, at least briefly, to strep toxic shock syndrome. So in recent decades, there's been a significant increase in highly invasive group A strep, with or without necrotizing fasciitis, and associated with shock and organ failure. And this has become known as streptococcal toxic shock syndrome. Streptococcal toxic shock syndrome can occur with the infection at any site, but most often occurs and associated with an infection of a skin lesion. So we're not going to go too deeply into this, except for to say that since it doesn't often occur from strep pharyngitis, we will not spend time on it. It can have a rapidly aggressive clinical course, and the case fatality can exceed 50%. So it's really another nasty thing associated with strep. Although, as I said, we're not going to dwell on it because it doesn't really have much to do with strep throats.
And most clinicians, when they think of toxic shock syndrome, they think of the staph toxic shock syndrome. And those of a certain age, when they think of that, they think of Rely tampons.
Yep,
and
you're
that was
exactly
that
right.
specific brand that caused toxic shock. And
that was a bad time in medicine.
that type of tampon is no longer nicely. I think we rarely see true toxic shock. It's out there, but much less likely than it was 20, 30 years ago.
Yeah, and we're going to just really briefly also mention glomerulonephritis, also a mouthful, and this is also usually caused by a cutaneous infection of strep and not by pharyngitis, although it's been known occasionally to be caused by strep pharyngitis. So we're not going to say a lot about that because that's a big, thick ogre of a topic as well.
And the big thing about that is, even if it came from a strep throat, treating the strep does not seem to change the likelihood of getting glomerulonephritis. So if you have that nephrogenic strain, it's probably too late. So we can't prevent it like we can. I think you're going next to the biggie.
I am.
Rheumatic fever.
Rheumatic fever, acute rheumatic fever to be precise. So this is an inflammatory response to strep pyogenes. So people think of rheumatic fever and they think of rheumatic heart disease and they say to themselves, wow, that's an infection. That strep actually got to the heart. This is not the way it works, and we'll talk about that in a second. But it generally occurs 2 to 3 weeks after a throat infection, but the timeline can be really variable. So this is not an inconsequential disease. There are about 500,000 new cases in the world annually, and it's estimated that about 330 or so cases of acute rheumatic fever occur yearly in children between the ages of 5 and 14. So they make up the bulk of these new cases.
330,000.
336,000 to be precise. At least 15 million people have chronic rheumatic heart disease as a consequence of this infection. So acute rheumatic heart disease at one time was the leading cause of death in children in lots of parts of the world.
Wow.
Just to give you some current context, in 2015, it resulted in 319,400 deaths, down from 374,000 deaths in 1990. Most of the deaths occur in the developing world, where as many as 12.5% of people affected may die from this. Descriptions of this condition are believed to date back all the way to the 5th century BC in the writings of Hippocrates. The disease is so named because its symptoms are similar to those in some rheumatic disorders.
Now, is Hippocrates the Greek Sydenham?
I think you have to be like after somebody to be called that, right?
I think Tom Sydenham would digress.
Yes.
He got his powers from God.
You call him Tom
evidently.
now. Nice.
Yes.
So rheumatic fever is a delayed sequel to Group A strep pharyngitis. This disease manifests itself as an inflammation of the joints, also known as arthritis, of the heart, also known as carditis, of the central nervous system, which manifests itself as, say it, Rob.
Sydenham's chorea, chick chorea.
Indeed, yes. Skin. Those skin findings are called erythema marginatum, and sometimes even subcutaneous nodules. So these 5 major clinical manifestations, any of which can be seen in rheumatic fever, were established as the Jones criteria.
And you know, a mnemonic that I still remember to
Say
remember
it,
this
man.
is CPCES. Now, CPC stands for Clinical Pathologic Conferences. Remember that?
No.
So it's Clinical Pathologic Conferences. CPCs eat poop. So that's how I remembered it. CPCES for chorea, polyarthritis, carditis, erythema marginatum, and subcutaneous nodules. You only need to know this on the boards, and that's about it. Probably not in practice. You can always look it up.
So this disease is considered to be autoimmune in nature. It most likely results in part from the production of autoreactive antibodies. We talked about this a little bit with Sydenham's chorea. And T cells, they're shown to cross-react with components of the group A strep. So they react to the group A strep. And then they also react to host tissues. So what happens is essentially your body ends up attacking itself because it thinks it looks like strep.
Right.
Crazy, cool, pathological, really neat stuff. So the medical importance of rheumatic fever is its serious cardiac involvement for the most part, with myocarditis or valvulitis, so inflammation of the valves, leading to death or the necessity for valve replacement. Now we're going to spend just a moment on pandas. As Rob said, we could spend episodes on this stuff.
But we won't.
And there's controversy, and Rob doesn't want to get embroiled in that. Pandas, also known as PANS. So strep infections that have been linked in a series of neuropsychiatric and movement disorders like Sydenham's chorea. Since the late 1990s, there's been this mysterious entity discussed in our field known as pediatric autoimmune neuropsychiatric disorders associated with strep infections. That was all in one breath, by the way. Or PANDAs.
That was nice. And, you know, you mentioned PANS. Really, PANS is different. That's pediatric acute onset of neuropsychiatric syndrome, something like that.
Right.
But basically, PANDAS is a subset of PANS.
Correct.
So there are other issues that may be similar, but they're not associated with strep, which I'll get to in a second.
You've been reading again.
A little bit.
All right. So the diagnostic criteria for PANDAS includes it happens prior to puberty, obsessive compulsive disorder symptoms, or chronic tic disorders.
With a really sudden onset. That's the
Yeah,
main
like
thing. It's
boom,
not it's just
all of a sudden
boom.
somebody
They
has
wake up
OCD.
and they have OCD.
Relapsing or remitting course of the disease, some motor hyperactivity or a reduced fine motor coordination, and the onset of the disease or symptoms exacerbation that seems somehow linked to a strep infection. So PANDAS was first described by Dr. Susan Sweeto's group at the NIH, the National Institutes of Health, so respectable place, in the late 1990s.
Back when it was being funded.
Yes. Don't get me going. Since the initial controversy regarding the appropriateness of this diagnosis versus regular OCD or tic disorders, the field has undergone a lot of change in terms of being able to investigate this. So biological treatment studies in children with PANDAS have provided evidence of biologic models and unique medical treatments for these patients. So it's really been much more intimately studied. So PANDAS, like Sydenham's chorea, is hypothesized to be the consequence of a post-infectious autoimmune-mediated cross-reactive antibody produced usually as molecular mimics, so what we just talked about in terms of the rheumatic fever, so your body's actually attacking itself, of the group A strep cell wall that resemble the host. So again, your body thinks that the host, or you, resembles in some way group A strep cell wall, and so it looks to attack it. If this postulated disease mechanism is correct, then by removing the offending antibodies by therapeutic plasma apheresis, or TPA, this should improve the symptoms. And indeed, in a study published in the Journal of Pediatric Psychopharmacology in 2015, Sweeto, so same author, same as the original author back in the 1990s, and her colleagues did just that. They took 40 patients with PANDAS, and they used therapeutic plasmapheresis, and this was done at Georgetown University Hospital. Again, another respectable place. So this isn't, poppycock. This is real. All patients were reported to have received at least some benefit from this pheresis, with an average improvement of about 65% in 6 months and 78% longer term. So this really looks to be a promising means of treating this.
You know, and I also have seen that reports about treating it just with IVIG.
Right.
Like we do with Kawasaki's,
Mm-hmm.
and which would be easier. And that certainly is something that's really interesting. There's also an article from JAMA Psychiatry just a month ago, May of 2017, from Denmark, which talks about these sudden onset syndromes with OCD, but basically makes the point that it's really just post-infectious, both after strep and other non-strep infections.
Yes.
So instead of concentrating on the strep part, it's just a post-infectious syndrome, somewhat like our other big post-infectious syndrome. I think it's called ADEM, ADEM, acute disseminated encephalomyelitis, where you get a viral infection and then you get brain changes. I've had a few kids over the years that have had really freaky changes in behavior, not necessarily OCD, and they end up getting an MRI and show these bright spots and sometimes get treated for it.
Yeah, so
that's
is
another
kind of,
real one.
Oh, for sure. This is definitely next level understanding of medicine, of how the body works. And so and just to get back to what you said about a little while ago about Andy Warhol being treated with prednisone for Sydenham's chorea. All of this seems to be kind of interrelated.
Right.
Sydenham's chorea, rheumatic heart disease, PANDAs. All of it a consequence of your body essentially working against itself. And how do we foil that process when your body's hell-bent on doing it?
Maybe it's going to be the microbiome.
Yeah.
No, really, maybe it is.
Let's hope.
Maybe it is.
We can only hope.
It's just, this is so fascinating too, because at least until recently, unless it's changed, I don't think the Red Book even recognizes any kind of association with strep and PANDAs.
Well, I mean,
the Red Book is our Bible for infectious disease in pediatrics.
Well, what do you do when you have a patient that you think has PANDAs?
First of all, it's very rare. If I have a kid who has sudden onset of OCD, I think I've had that once happen, and I did end up talking to infectious disease, and I did end up, who are you going to call? Infectious disease and a child psychiatrist.
Yes.
And we did end up treating for strep and doing some titers and such. But I got to say, it's just very rare. So that's why you need a center to look at these cases.
Yeah. I mean, I've had a couple parents who have been out and about Googling when their children started to act a bit OCD-ish, relatively acutely. And we're hoping they could get the quote-unquote test for this. Now, you can certainly do titers. You can do ASO titers, and DNA ACE titers. But the problem with this is that oftentimes this presents itself, a long time after the infection as well. A lot of it is it's very confusing to try to treat.
A lot of the times
really
when this does come up, to be honest, in a patient who's had OCD, gradually onset, long-term, and has a big family history of anxiety. So it really doesn't fit this PANDAS acute onset.
So let's get down to the strep diagnosis here. So the gold standard for the diagnosis of strep pyogenes pharyngitis is a positive culture from a properly collected throat swab specimen. A properly collected swab is a swab rubbed on both tonsillar pillars, avoiding the lips and the tongue.
And this is an art.
It's very much an art.
And we talk about holding with the ears. You got to have the right hold, and you got to do it fast, and we'll get back to this, but I usually do 2 swabs at once, the rapid and the regular.
Yes.
You got to twirl them as you go up and down on that tonsil, and if you don't do it right, it's worthless.
Yeah, it really is. And this is another thing. We talked about teaching a student how to hold the otoscope, in the earwax episode. Teaching a student how to actually use the tongue depressor is another really crux of the physical exam, because a lot of people will just hold the tongue depressor and expect the child to hold still while they push down on their tongue.
Good luck.
Good luck with that. Right. I mean, I find myself looping my thumb down under their chin and using the tongue depressor on top, so I have a lever to kind of force that tongue down.
And the teeth clenchers, you have to go to the side, get behind those molars, and kind of get in there really quick.
You betcha.
You have to gag them and then just get it done.
Either that or, a sharp object.
So here's a question. When I started, some of the older people in my practice, they had a routine practice of having kids come in for strep culture only that was done by the nurses. And over the years, I've been more and more comfortable. If we talk about not culturing, if we don't think it's strep, and we'll get to the carrier part and such, I think someone with experience needs to look at that throat, take a history before they just do a culture, or else you're going to just do cultures on kids who shouldn't have a culture and start treating kids with carrier states who don't have acute disease. So do you do that in your office? Do you have them come in for
For just the culture?
owner by the nurse?
No, the only time I ever do that is if I am trying to discern whether something's a carrier.
Exactly. So later on when they're okay. But I think that's still done out there a lot, is they come in quickly for a culture. I don't think that's great pediatric medicine.
So now rapid antigen tests are used in most clinical settings. And so the sensitivities of this, these tests are anywhere from 58% all the way up to 98% sensitive, but they've never equaled the sensitivity of a culture test, of a regular culture. These are really highly specific, generally 95% or higher. So a positive result provides an immediate diagnosis, and it precludes the need for a culture. So national advisory committees continue to recommend that negative rapid strep results be confirmed with a throat culture in children and in adolescents.
Do you have blood agar plates in your office?
You bet we do.
So do we.
Always have.
And do you get paid by the insurance companies for them?
Yeah, like a quarter?
Or nothing, rarely.
Or nothing.
We basically decided as a group that we're going to eat the cost of it, that we want to do a rapids. But if you send it out to LabCorp request, it could take 3 days.
Sure.
And when I first started practice, before the rapid streps, you did the culture, you gave them a day or two of antibiotics, and then waited till it came back. And so you got a lot of unnecessary antibiotics.
Yes.
So I don't feel comfortable sending them out. Other people sometimes, if you send a kid to get the culture at the lab, I just don't think they're that good for kids.
No.
So I don't trust their
I've never done that.
technique as much, so I never do that either.
The delay is very frustrating for parents, and you're delaying. When we talk in a minute about
and treatment,
what helps, you're delaying the treatment. Now there was for a while and it was put out by one of the major infectious disease people, the theory that even if you know it's strep, you should wait a couple of days to treat it.
Well, I do agree with that, and I was going to get to that later. That there is no rush. You want the kid to feel better, but there's no rush in terms of preventing things like rheumatic fever and such. And there are studies that show that it's more effective if you wait a few days. So I do, they're in front of you, I'm going to treat them, but I do try to tell the families that there is no rush, and actually delaying a day or two may reduce the chance of recurrence.
Yes.
But you don't want to wait too long.
Right.
And it goes along also with that a sore throat at night is not an emergency.
No.
That there's no downside. Give them Tylenol, ibuprofen if you need to. There's no downside to waiting to the next day to do the culture at all.
No.
It may be an advantage to waiting to the next day.
Absolutely. My understanding of that has always been that your body has the opportunity to build antibodies to that, at least that strain of strep. By delaying the treatment, you may be able to build up those antibodies. So if you ever encounter it again in the future, it won't be a problem for you.
Exactly.
So I was always taught that you can wait as long as 9 days to treat strep.
That's a long time.
As long as not. I mean, without the consequence of rheumatic fever.
Right.
So if somebody says, "Oh my goodness, he's had this sore throat for a week, and now you're telling me he has strep throat, does that mean he's going to get rheumatic heart disease?" No, if it's only been a week. By no means am I proposing waiting to treat strep throat, but it could be waited on. So this is another point that there's no incredible urgency to do this from your body's standpoint. The most popular rapid strep tests on the market today are lateral flow immunoassays. With this test, antibodies specific to the group A strep cell wall proteins, or antigens, are coded onto the test line area of the test strip. Once the sample is placed, the extraction from the throat swab specimen migrates up the strip, much like a pregnancy test. 2, and if group A strep is present, it reacts with the antibody to group A strep on the stripe and generates a colored line in that test region.
I usually mention that whole pregnancy thing to the boys. Say, it's like a pregnancy test. Teenage girls, I just don't go there. Just too close. Well, it's not that funny when I say, it's like a pregnancy test.
So sometimes if I have the time, I'll actually bring this test strip in and show somebody just to say, look, it's positive. This is how we test for it.
And kids actually, little kids kind of think it's kind of cool.
They do.
And you can teach a little bit of science, so it's kind of fun as you sit there waiting for it to finish.
Right. So the presence of this line on the test region indicates a positive result, whereas this absence indicates a negative result. And to serve as a procedural control, a different color line will always appear in the control region, which is above the test region. So false negative results are associated with poor specimens, uncooperative patients, inexperience, or testing a patient too early in the course of the strep. So one of the things that we're probably going to be running into in the near future, Rob, is the fact that these test strips are now available on Amazon. It's about $38 for 25 of them, so get ready to respond to those phone calls.
I did not know that.
Yeah. In fact, I looked it up last night. Yeah.
And
so,
are they also going to teach them how to swab their own
that's
kids'
the thing.
throat?
Yeah. So all of you pediatric providers, just last week or so, we occasionally have a hospital nurse mom who will swipe one from the hospital and test and be positive. And, depending on the situation, I may or may not want to bring them in. That's one of those almost professional courtesy type of situations that you find yourself caught in as a pediatrician. Yes,
if they're a nurse and they did it, I'm going to treat it.
Mm-hmm. So let me ask you this: have you ever used a kid's mucousy saliva to test, like one of those kids who's completely freaking out about having his throat cultured?
No.
Okay, so I have.
Never.
A handful of times, but here's how I do it. I do it the same way we do the urine tests. It's only a good sample if it's positive. So I'll occasionally say, okay, fine, I'm going to try this. Go ahead and you hock up a loogie over there, and spit it into this cup for me. And I will touch my swab to it, and we'll test it. And if it's positive, I don't have to do the throat test. It's not documented anywhere.
I don't feel comfortable with that.
Mm-hmm. Okay. Well I do, especially when I'm looking at something that clinically looks like strep to me as well. We don't make it a rule. We don't advertise it, but I have 2 or 3 kids that I'll do that with. Now, if it's negative, then I'm going to go for the swab anyway. So many clinical labs are now able to perform polymerase chain reactions or PCR testing for strep. Rather than testing for the cell wall antigen of the strep bacteria, the PCR tests for the nucleic acid sequences that are associated with the genes unique to strep pyogenes bacteria. In many situations, sensitivity and specificity of the PCR compared with culture are 100%.
Wow.
Yeah, in one study, PCR testing of strep nucleic acid sequences was so exquisitely sensitive that the technique had a limit of detection of just 1 or 2 strep bacteria. So it was able to detect just 1 or 2 bacteria. That is crazy cool. And best of all, PCR takes about an hour to perform and costs less than $3 per test. This is very likely the wave of the future.
Just slow down there a little bit. I mean, you say an hour, but an hour is an hour. In terms of they're in your room, they're out. And how easy is this going to be done in the office ever? And if it's not, you have to send them out to a lab, and then who's going to do the culture?
Right.
And they may say $3, but is insurance going to pay for it? So that is exciting, but this.
Yeah. Well, I wonder.
I won't hold my breath.
If we're going to be able to do these in the offices, or if something like this could be done with our rapid strep test first, and if that's negative, this is the backup. I don't know from that standpoint.
It certainly seems to be more accurate, but we'll see how long it takes to get into our office.
Out.
But when I was training in the 80s was when these first came out. It was the old latex agglutination types.
Yes.
Do you remember when they first came out when they were testing it, or were you partying in Wildwood in the mid 80s when I was a resident
with my fake ID?
Right.
Yeah.
Right. So in Children's Memorial Hospital is one of the main places that started this, and we did a lot of early studies on it. It was Stan Schulman. So just as an aside, Dr. Stan Schulman is still waiting for Dr. Elfman's rapid strep data.
I didn't know Jenna Elfman was a doctor. Whatever happened to her?
It's her father. Oh, I like Jenna Elfman. All right, I digress. All right, now we're jumping into treatment.
Treatment, yeah. So strep pharyngitis is almost always a self-limited illness. And many researchers have questioned whether antibiotic treatment is even warranted at all. I mean, what did we do before we had antibiotics? Well, people died.
We died.
That's exactly right. However, such treatment can be justified for 3 reasons.
3. Number 1.
Yeah. I know. Rob digs this stuff.
Come back to Hamilton. Number
absolutely,
1. Yep. The 3 strep commandments. Okay.
So let's alternate these. Okay, ready, go.
Treatment shortens the duration of the severity of illness. I mean, absolutely. If you get the antibiotics, you'll feel better quicker. We talked about you can wait a few days and you can take Tylenol, ibuprofen. But yeah, one of the reasons we want to treat is we want the child to feel better. No question on that.
Number 2, treatment prevents rheumatic fever. Well, we just talked about this, right? Rheumatic fever is pretty nasty business. While this rationale for treatment remains compelling in many resource-poor countries where the incidence of acute rheumatic fever is high, in industrialized countries, the relative risks and benefits apparently no longer support this treatment goal in routine cases. Would you feel comfortable not treating, Dr. Walter?
No, and actually preventing rheumatic fever is the main reason I was taught to treat. So I don't disagree because we don't see as much rheumatic fever. I've seen a couple in my training, but I would not feel comfortable with that at all. No. You got to treat it.
You betcha. All right. Robbo?
Oh, I'm there for number 3.
Well, yeah, we were doing the Chip and Dale thing here.
Okay.
We're alternating.
Number 3, to prevent suppurative complications of pharyngitis. Antibiotic treatment is shown to reduce the incidence of secondary complications, even otitis media, ear infections, and sinusitis. An additional benefit of treatment is that it reduces the spread of infection to others, again, for outbreak control. The clinical practice guidelines in the United States recommends treatment for children and adults with proven strep pyogenes pharyngitis, and guidelines from some European countries are similar, while other countries do not recommend specific diagnostic testing or treatment, since treatment has a small impact on the natural history of pharyngitis, and the incidence of suppurative and non-suppurative complications is low in these populations, and I completely disagree, even though I just read that.
Yeah. So the U.S.'s clinical guidelines, at least, were developed by the gentleman you just recently mentioned, Stan Schulman, and his group in 2012. They're the most recent guidelines for strep that we have. So penicillin has been the main choice of treatment for group A strep for decades. The organism is still universally susceptible to penicillin and to many other beta-lactam drugs. Amoxicillin is similarly effective, and it's often preferred because it has a longer half-life, and frankly, I think it's a little bit better tolerated in kids.
Do you use penicillin at all, ever?
No.
I never use it.
No, amoxicillin is just so readily available and easily tolerated that I just don't even think about using penicillin these days. So once daily dosing of amoxicillin appears to have a similar effectiveness to twice daily dosing regimen, and this has been published in a couple different papers. But how do you dose it, Rob?
You know, I just started. We had a Bugs and Drugs talk a few months ago, and that was the one thing I was like, wow, I should be going to once a day instead of twice a day. So I've just started to do that. The other thing, again, is that you need much lower doses to kill strep.
Yes.
So the once a day, 50 per kilo total per day, the one thing I get into is how big of a dose of amoxicillin do you give? And we've talked about that we have different styles on this. So if you have a 30 kilogram, 66 pound something kid, and you want to do 50 per kilo, are you giving a single dose of 1,500 milligrams to that young child?
Right. Well, so I don't usually dose it once a day. I'll usually split the dose. And this is for a couple of reasons. I mean, first of all, I think a once-a-day dose in a larger child can be a little bit prohibitive from a digestive standpoint. You know, it may upset their stomach. And the second thing is when we have medications that we can dose either once a day or half the dose twice a day, I'll almost always go with a half a dose twice a day. And that's because people miss doses. And so I'd rather have them miss 1 of 2 doses a day than an entire day.
Right. And what I try to avoid is 3 times a day.
Right.
Which Clinda, you can't avoid it. But otherwise...
You see a lot of the medical aid units still doing that.
Yeah,
with
the TID
amoxicillin.
at 125 per 5.
Something.
You know, before I forget, just to mention that the other important thing for families in treating strep is that they're contagious for 24 hours.
Yes.
After they start the antibiotics. So they're usually out of school the next day. And I tell them to change your toothbrush the following night. Not right away, but the following night.
I'll tell them to give it a couple days to change their toothbrush. And interestingly enough, there was recently a paper published that talked about the fact that within 12 hours, you're no longer contagious. I'm not buying into that yet, but if there's more research that's generated that way, then perhaps if a child's feeling dramatically better by the next day, they can go to school.
And that would increase school attendance and also decrease the amount of time parents have to take off for their kids. So that would be huge.
All kinds of
if
goodness.
that was replicated.
Okay, so that's so amoxicillin is usually our go-to drug with this, but cephalosporin can be used in patients with a history of allergy to penicillin or amoxicillin that isn't the immediate hypersensitivity type. Macrolide antibiotics are another alternative, but the resistance to this has become really quite common.
Yeah, I stay away from the Zithromax of the world, except for respiratory things. So cephalosporin. So which cephalosporin do you use?
Most frequently, I'll use Keflex, although sometimes I'll use Ceftonir. Ceftonir is a little tricky, though, because even though it comes as a generic, the generic companies have jacked the price way up on that.
That's true, but the one thing about Ceftonir, which I haven't seen about the other cephalosporins, is that studies show you can do a 5-day course.
Yes, 5 days
or a
BID.
7-day course. So if you had someone about to go on vacation, you can get away with doing 5 days.
Yep.
On the other hand, I think Matt and I both don't want to use any broad spectrum any more than we need to, so we'd rather go to amoxicillin. But remember, you can do, at least by the data, you can get away with 5 days with Ceftonir, but I don't think you can do that with Keflex or Cephalexin.
No, not to my knowledge. And then the other thing that sometimes we'll institute if a child has broad allergies to antibiotics is using azithromycin or azithromax. And,
right.
And what ends up happening here
even though we don't like to use it that
even
much.
though we don't like to use it that much, we still do in this situation. And the dosing on this for azithromax and for some reason, some of the folks out there who aren't specifically pediatricians aren't aware of this, but the dosing is actually different than the dosing for ear infections and pneumonia. So the dosing is 12 per kilo once a day, as opposed to 10 per kilo the first day, and then half of that days number 2 through 5.
Exactly. Sometimes in the old days of paper scripts, I'd write down this is for strep, so the pharmacist didn't think I made a mistake.
Yes. So, and there are some other meds that people will use. People will use clindamycin, which is incredibly nasty.
And 3 times a day.
Oh my gosh! The best description I can come up with for Clinda is that it tastes like stinky feet smell. I mean,
you've
it's just
said that before.
Awful. Oh my God, I can't get over how terrible it is. And then another option that frankly I'd forgotten about until I was looking into this is chlorithramycin or Biaxin. Yeah, do you remember that? We used to use that a lot.
And I don't use it much anymore.
I never use it. I forget about it. But one thing I remember about Biaxin is it left a really distinctly metallic taste in your mouth. Nasty stuff.
Okay, so after the break, we'll be right back. Okay, some more pearls. Matt, do you tell the testicular torsion story?
Probably not the same way you do, Rob.
So my testicular torsion story, my patients know this really well. It's like at 11 to 12 years of age for a boy, I usually talk about testicular torsion story. And I tell them the story of my true 14-year-old patient who woke up in the middle of the night and came into his mom and dad's room and said, "My stomach hurts." The mom felt his stomach, his head, put him down to bed. 2 hours later, he came back in saying, "It still hurts, but it's not my stomach, it's my ball." And the dad looked, it was swollen. They called me up. I said, "Go right to the ER." And they were waiting for him. They did a Doppler ultrasound, which is kind of a cool machine, to see if there was blood flow to that testicle. There was none. They whipped him up to the OR. In less than 30 minutes from hitting the door, Dr. Sonny, we both know Dr. Sonny, the urologist, went in there and it was black. And he lost his testicle. And this testicular torsion is kind of a freaky thing that you can't always predict. It often happens to young boys, teens, and preteens when they roll over at night and they get this pain that doesn't go away. And when you have a bad outcome like that, when you lose a testicle, it's not because the parent didn't do the right thing or the doctor didn't do the right thing. It's because the teenager was kind of embarrassed and didn't tell someone that it hurt. And so I got that lesson from Sonny Figueroa, that's the key thing for us to tell parents, to tell their kids, that if you have pain there, that you got to do something about it. Now, if they have pain, if it goes away, no big deal. And if it doesn't go away, it doesn't mean they have a torsion. But when you miss a torsion, it's always sad that you feel like if they would have gotten there earlier. So I really tell the kid once about that. I also tell him that he has 2 testicles. He only needs one to do everything, but he'd probably like to keep both of them, and they usually agree. And then once I tell that story once, the next year when I start to tell it again, they go, I know that story. I don't want to know about it. Certainly I probably have kids who go to the ER too much because of that. They get freaked out, but I'd much rather have false alarms than to have a kid who ends up with the Virgil Livers Chicago Bears Uniball situation. Which then later they'll get a prosthetic testicle, which my patients have had, and it works out fine. But still, you'd like to keep both of them. Yeah. Agreeing? You're kind of cringing over there, Matt.
No, rightfully so.
I also like to ask in a big family with the other kids in the room, now, who is the best kid in the family? It's always great to see their response. I mean, if they're like, me, it's me. I know they have good self-esteem. If they're basically saying, oh, it's my brother, my sister, I will worry a little about their self-esteem. The right answer is yourself. You should like yourself. But I always love the dynamic between the kids.
Yep.
And they usually pick the dog.
Weren't there studies done where they could track where someone was looking, and if they were shown a picture of multiple people with themselves in the picture, they should always look for themselves first?
Right.
And if they didn't, then maybe there was a little bit something going on there from the standpoint of their self-esteem, among other things.
Exactly.
Yeah,
I mean,
sounds like a similar situation.
You don't want some kid to be too full of himself, but you want him to say, yes, I'm the best kid in the family. Even though the mom looks like, I know you're not the best kid in the family. I always tell the mom, it should be a tie for you, even if you don't mean it.
Yeah.
Other things, I think a pearl that I think both Matt and I do is that when you get a kid going into 9th grade and going to the first year of college, that's a huge visit.
Yes.
Because that first semester sets the tone for everything. And ninth grade is going to be harder than middle school, and the first year of college is going to be completely different than high school, and a lot more free time, and you just got to impart the best you can that they really need to get off to a good start.
Yeah. A lot of my patients I've been seeing for many years, just like Rob has been seeing his patients for many years. And so you have a relationship with these folks. And so oftentimes I don't have to get into a lot of nitty-gritty descriptions in terms of what one should or shouldn't do. They know what they should or shouldn't do. Instead, I'd rather allude to it in kind of broader terms. And I'll say things like, you know what? If it seems like it's stupid, it's stupid. So, use the old carpenter's rule, which is measure twice, cut once. That means think about it. Think about it again. Then make your move, because honestly, it doesn't take much to really change your whole life. In fact, I'll usually, depending on my mood, I'll say either 5 seconds is stupid or 10 seconds is stupid can change your entire life. And it's so true, whether that's getting in a car with someone, whether that's taking a toke on a doobie, whether that is being in a sexual situation. 10 seconds is stupid is going to change the whole course of your life in some situations.
And the correlate that also is, I tell them that if you ever say to yourself, I can't call my mom because she'll kill me, that's when you call your mom.
Oh, absolutely.
We see it all the time. They say, I was going to call. And I say in front of the parents, I say, if you call them, they will get you silently. They will pick you up. They will bring you home. They will tuck you in. They will kiss your head and put you to bed. The next morning may be a scream fest, and they may deserve it.
Right.
But, they just make the mistake where they think that they can't call home.
At least you're safe and live.
Right.
Did you ever have your kids use code words with you at all?
Did not.
No, I didn't, but I do suggest it to people. And so what we're really talking about there is if a child finds themselves either frequently or, for that matter, even infrequently in an awkward social situation, they can make a phone call without embarrassing themselves, but they'll use a certain term or phrase, and that will indicate to their parent that they're in trouble and they need to be picked up. Whether that trouble is social, whether that trouble is physical, whether that trouble is they're someplace that they don't want to be because of what's going on in any extent, that can be a very face-saving maneuver.
No, that makes sense.
For a lot of kids.
Especially if it's a word that's not going to embarrass the kid.
Right.
They say raspberry.
Right. Are we going to grandmom's tomorrow? Anything along that line, something that you can just slide into a conversation and isn't going to seem unusual to your friends. So that's certainly something to think about.
I like that code word.
Yeah, code word or code phrase.
Would you do that and then give them a fist bump?
If I were you, I would. They'd run in the other direction. No, I think that what oftentimes we as pediatricians explaining to parents, the one modus operandi for a teenager is do not embarrass myself. And they will go to tremendous and oftentimes dangerous lengths to avoid embarrassing themselves. And this is oftentimes how kids get into situations when you think to yourself, why in the world would you, who knows better, have done something like that? Well, they did that because they didn't want to be embarrassed. And that is really the crux of a lot of teenage turmoil.
Right. Let your parents and your pediatricians embarrass for you.
You betcha.
All the time.
I'm happy to embarrass you. I've embarrassed my own kids many a time.
All right. That was our little break. We'll be back soon. Say goodbye, Matt.
Goodbye, Rob.
Okay. Lastly and finally, the dreaded strep carrier state. Group-based strep carriers present a great deal of angst and confusion for providers, patients, parents, researchers. It's not only difficult to identify which patients are quote-unquote carriers, but there exists a fair amount of controversy on what to do about them if you identify them.
So the existence of group-based strep carriers was initially described in pre-antibiotic times when there were outbreaks of group-based strep. So despite the fact that there weren't effective antibiotics to treat this situation, researchers still were able to culture the people who were in the community and found that there were a fair number of people in the community who did not demonstrate group-based strep symptoms at all, no obvious signs of illness, and they didn't suffer from any of the complications of strep, but nonetheless, they were found to have strep in their throats.
And all this begs quite a few questions. Are these carriers a source of strep transmission to the rest of the community? Does being a strep carrier put that carrier at risk for invasive disease? Does being a carrier increase the risk for the carrier to suffer from non-suppurative sequelae, such as rheumatic fever? How should a carrier state be interpreted when the carrier has a sore throat? And what about Naomi? Stay tuned for this and other questions next week in Love of Chair.
Who is Naomi? What's
Electric
that from?
Company. Look it up. Electric Company.
All right. I'll take your word for it. So it's been known for quite some time that carriers have little, if any, risk to develop acute rheumatic fever. This is largely based on the fact that patients who have had rheumatic fever have elevated ASO, or anti-streptolysin titers. But those with group A strep isolated from their throats who did not develop rheumatic fever did not have elevated ASO titers. Since carriers do not develop antibody responses to ASO, they've been determined not to be at risk for acute rheumatic fever from the carrier state.
It's also known that those who are carriers of group A strep are not effective transmitters of this organism to others. Although transmission is theoretically possible, it's far less likely than the spread of strep from a child who has symptomatic strep infection. So, carriers will not spread it around. There's no equivalent of typhoid Mary. There's no strep Mary running around giving strep to everyone.
So for pediatric providers, the carrier state creates fits of confusion in reference to evaluation and treatment, particularly in those with symptoms of acute pharyngitis or an acute sore throat. Most of the time, the conundrum presents with a carrier having an upper respiratory infection, initially noted as a sore throat. Many viruses in the community have only a sore throat and fever as their initial symptoms, and oftentimes that's when parents will call and ask for their child to be seen.
So again, these children with sore throats, with a runny nose, a cough, maybe conjunctivitis, they really have a slim chance of actually having symptomatic strep. And that's when the experts recommend do not test these kids for strep because their symptoms are not the classical presentation and you're going to overtreat carriers. And we all know Magdi Attia at DuPont, one of our favorite ER docs. He did a lot of studies on this, and there's been a lot since then about the pre-test probability, and that if there isn't a high pre-test probability, don't get the test, and that becomes the key. Everything depends on who you test and what your criteria are for doing the test on the patient who's in front of you.
Yeah, so what ends up happening oftentimes is a provider acquires a rapid antigen detection test or a throat culture. One of these, if not both, end up being positive since the patient is indeed a carrier, but the carrier state's completely uninvolved with the child's present and evolving illness. The virus is making the child sick, and the strep is merely an innocent bystander. Are you an innocent bystander? Apparently to this podcast you are. Yet the positive test is determined to be indicative of an acute strep infection, and so then an antibiotic is initiated.
You're stuck. If you get the test and it turns back positive, you have to treat. So you have to decide if you want to do the test. So this happened to you where you don't think it's going to be strep. We'll talk about it. You do it anyway. And then you're about to have them leave, and then the faintest little bit of a pink shows up, and you're like, ugh. Do you say something? Do you call it strep or not? You don't want to give antibiotics. What do you do, Matt?
Well, when it's a trivially faint line, and these things are open a little bit to interpretation, and I'm not at all convinced the child has strep, then more often than not, I'll wait for the culture to come back. If the culture indeed is positive, then we have to deal with what we have.
So you tell the parent it's negative, and then you set up a culture.
Indeed.
Okay. It's tough.
It is.
It's a little bit pink. Is by the definition, as far as I remember, for these rapid streps, if you see pink, it's positive. It's like a pregnancy test. It's not like gradations. You either have it or you don't. But we've all been in that situation where we're not sure.
Yeah, so it's very frustrating. I mean, there's simply no good way to discern the difference between a strep carrier with a viral sore throat and no other distinguishing viral symptoms at the time and an acute strep infection. So studies show that if there are 10 million cases of strep pharyngitis diagnosed per year in the U.S. and the carrier rate is around 15%, then about 1.5 million patients would be treated who did really not need to be treated. They did not need antibiotics. And then this phenomenon leads to an increase in antimicrobial resistance, on serious side effects, of increased healthcare costs. So it's not a trivial matter.
And going back to then all the kids who are cultured who shouldn't be, the study in pediatrics in May of 2017 by Shapiro et al. At Boston Children's ER, which is a fairly respectable ER, he found that 2/3 of the strep tests done in that ER in kids were done on kids with viral features of cough, rhinorrhea, conjunctivitis, or all vesicles and ulcers. So even there at Boston Children's, they are doing cultures on 2/3 of kids who may not need it. And so with 15% carrier state, they're probably over-treating lots of kids.
Yeah, I mean, again, a very respected ER, Boston Children's.
It's all right.
Compared to what, Northwesterns?
It's all right. It's okay.
You're going to get hate mail, man.
They're pretty good.
There are other things to consider as well. Does the treatment eradicate the carrier state? So 2 studies, both done over 10 years, indicate that if certain antibiotics are used, one of the studies was azithromycin at a dose of 12 milligrams per kilo for 5 days, and that actually yielded a 91% eradication rate. And in another study, a 10-day course of oral clindamycin resulted in a 92% eradication rate. However, the rate of group A strep resistance to macrolides and clindamycin has been slowly increasing, and so these studies were done about 10 years ago, so not really clear where we stand now.
The question is, do you want to get rid of the carrier state?
Right.
And then how do you decide the carrier state? And if someone keeps having strep, I try to say, okay, come in when you're well.
Absolutely.
And
I do the
then
same
let's
thing.
get a culture.
Yep.
And if it's positive, then you decide, do you want to try to do something? And if it's really affecting their lives, if every time they get a sore throat, and especially if they're going to in different places and they're getting cultures every time, then I am certainly fine with saying, okay, let's try to eradicate it. And my favorite is clindamycin. 10 days of clindamycin.
Yeah, if you can muddle your way through the god-awful taste of clindamycin. So, but, so you lead us into a good point. I mean, is there ever a time? The big question here is whether or not eradication benefits the carrier or the population in general, since there is little, if any, risk for sequela in the carrier state, and the risk of spread to the bacteria to others is really low, as we already discussed. It would seem that there's not a lot to be gained by treating strep carriers.
Right, for the community at large. It's just the individual child who seems to be getting cultured each time, and maybe they insist on it, and you think, you know what, let's try to break that cycle.
Yes, so let's bring in the experts here. So there are indeed expert guidelines that recommend not treating carriers except for very particular circumstances. And those circumstances include, number 1, as part of measures to address a local outbreak of acute rheumatic fever, invasive group A strep disease, or post-streptococcal glomerulonephritis.
When was the last time you remember an outbreak of either one of those?
Never.
Okay.
However, around the world, these
world.
things absolutely do occur. Number 2, an outbreak of group A strep pharyngitis in a closed or semi-closed community. So I'm imagining at this point, for instance, maybe a military base,
a religious,
group. A monastery, something along that lines. Number 3, a personal or family history of acute rheumatic fever. Okay, that would really make things pretty confusing.
And I also will say I've certainly taken care of rheumatic fever over the years, mostly in my residency and such. But in the last 20 years, I haven't seen a case. How about you?
I have at least one child who the experts are convinced had rheumatic fever, and he's currently taking penicillin every day.
So you did have one.
I did have one. And the 4th, if multiple episodes of strep pharyngitis are occurring within a family over a period of many weeks, despite the appropriate treatment. So, and that's a little bit dicey in terms of whether I think I agree with that or not. Yeah, that's a little iffy.
So it really gets back, in most cases, when we think about treating the carrier state, is to eliminate the ongoing confusion when a patient is seen repeatedly with episodes of symptomatic pharyngitis and giving antibiotics over and over again, and you're not quite sure if it truly is symptomatic strep or they're just picking up a carrier state.
Right. Yeah, because the carrier state doesn't prevent a person from acquiring other strains of group A strep. As we know, there are multiple strains of group A strep. If you're a carrier, you're really only carrying one of them. And because of this, you can still acquire strep throat, which adds yet another layer of confusion. So because of this, it's important to continue to test carriers and treat them when they have symptomatic episodes of pharyngitis that don't have any associated viral findings. By limiting the carrier state, the provider has hopefully cleared the deck.
Right, so clear the deck, it's negative, so next time they have a sore throat, you can feel comfortable that it truly is strep. We talked about clindamycin. The other big regimen people use against the carrier state is the penicillin plus rifampin.
Yes.
And I don't love rifampin because it makes your pee and your urine and your sweat kind of
and your
pink.
tears.
And
it's
your
kind of
tears.
cool.
It is kind of cool. So
I remember having to take it during my residency because I was exposed to, I think it was meningococcal meningitis.
Right. The different HIV also, different invasive
I
meningitis.
noticed then every time I cried, it was orange. Yeah, I used to do a lot of crying in residency. I cried myself to sleep.
Are you telling me that
I
made you cry?
You did.
I was
That's right. You were my big cheese.
I was his resident. I made him cry. Now, it's interesting. The other thing that you can use is a dose of penicillin IM plus the rifampin.
Ouch.
And do you keep IM antibiotics in your office?
We keep ceftriaxone here, and that is the only IM antibiotic.
Do you use it for like an ear infection, or if
we
you
use it
septic?
typically for very uncomfortable and recalcitrant ear infections wherein a child is sick with it. Fevers, misery in general,
and it's a single
not
dose.
Responding. Single dose, and then I think the protocol is to have them return within the next day or two to see whether or not they need a second dose.
Right, so we don't keep any IM antibiotics, but it's interesting that you keep the ceftriaxone, but if you're going to use ceftriaxone for this, you need to give it 3 separate days.
Yeah.
And the penicillin is just 1, so I don't think you would even think about using ceftriaxone for it.
No, really, it's just those really tough otitises with a miserable child that we save the ceftriaxone for. And to be honest with you, we don't use it very much at all. I mean, maybe a handful of times a year.
So coming around to last thing, we just talked about the carrier state, but multiple times over these podcasts, we talked about tonsillectomy and getting airy tonsils. So certainly this is another area that you come back to, okay, when do you decide this is too many times? If you think it's real strep pharyngitis and when you get them out. So the guidelines say greater than 6 severe throat infections per year. And a severe throat infection includes having a fever of 101 or above and cervical lymph nodes that are tender and exudate. And especially if it's strep. Some also say greater than 7 in a year. They also say greater than 5 a year for 2 years, or greater than 3 or more a year for 3 years in a row. By the guidelines, not many kids are having that many, and I don't always wait that long sometimes. And we touch base about FAPA and some of those things, about how those seem to really respond well to getting your tonsils out. And I will add that a lot of those studies show that there is an issue of the microbiome in the tonsils. So it all gets back
did you say microbiome?
to the microbiome.
Yeah.
I did say microbiome.
All roads lead to the microbiome.
Are we done with strep?
We're just about done with strep. That carrier state, continues to present confusion. I think it probably will continue to present confusion. There are ways to treat it. I wish there was treatment anytime we're confused, we're worried by the status of something. And this makes me think of the current healthcare reform. Maybe I'm thinking maybe a nice pop of a little bit of benzathine penicillin G to the buttocks of each member of Congress would do the trick, huh? Isn't it crazy? Yeah. It's crazy that that's the treatment for syphilis too. So I don't know. I don't want to go too deeply in that. But I guess the fact that so many of our federal legislators are demonstrating an intentional disregard for the welfare of the weakest members of society by proposing massive cuts to Medicaid so that the wealthiest members and the drug companies and the insurance companies can get a sweet tax break could broadly be interpreted by anyone who thought about it as being kind of a social issue, a social disease, for lack of a better term. And by the way, 39% of children in this country have Medicaid as their insurance.
And as we talked about about the lobbying for CHIP, 95% of kids are covered now, 9 million CHIP, 36 million on Medicaid, and almost half of the people covered on Medicaid are children. So when they're taking huge chunks of funding from Medicaid away to give huge tax breaks to the richest people, they're taking coverage away from kids. Very cost-effective coverage. 50% are kids, but they only take 20% of the costs of Medicaid.
Yeah, sorry, folks, but nothing irritates a pediatrician more than having the health and well-being of children sacrificed for what really is blatant greed.
And the opioids. We keep talking about the opioid. It's a bipartisan thing. 70% of opioid treatment is from Medicaid. You take money from Medicaid, you're taking money from opioid treatment, which is a crisis. There's people dying every day.
Yeah, so finally on this topic, we want to give a shout out to 2 California congressmen and physicians, so they are both, Representative Raul Ruiz and Representative Ami Bera, who held a press conference at the Capitol just recently, donning their white coats to protest the current health bill as it is proposed. And I agree entirely with Representative Ruiz, who said, and this is a quote, "This is not a political question, this is a moral one."
Amen.
Amen to the amen. And that wraps up our episode today. Strep and the woes of this country in the hands of Congress for its health care. And we will see you next time.
We'll be back soon with some follow-up of different topics that we've done during this season.
To wrap up the first season.
Say goodnight, Matt.
Good night, Rob.
Podcast Pediatricians Productions. All rights reserved.